Kristen Atchison here, and we're talking about psychological disorders. Specifically today, we're going to talk about anxiety disorders and disorders that are related to stress. So, anxiety disorders are uncontrollable fears that are disproportionate and disruptive. Now, we all have felt anxiety. You, me, and everybody else in between tests or life events or just general worries. Everybody has experienced anxiety. So that's a really familiar emotion, but it becomes a disorder when it is maladaptive, uncontrollable, and disrupting everyday moods, activities, and thought processes. So once again, it starts to get into that way of functioning is when we've moved into disorder, okay? So when we have these maladaptive and uncontrollable situations, when it disrupts everyday function and activities and mood, this is when we've moved from typical, just normal, you're a human being and you're alive anxiety into a possible anxiety disorder. So we're going to talk about a couple anxiety disorders today. We're going to talk about generalized anxiety disorder, panic disorder, and specific phobias. Now, there are other diagnosed DSM anxiety disorders, social anxiety disorder. There's other not specified ones as well. So this is just three of the ones that we're going to kind of talk about. We're also going to talk about obsessive compulsive disorders here. And these are anxiety related, but they're not actually classified as an anxiety disorder in DSM-5. So first, let's kind of start out with the prevalence of anxiety disorders. So this data from NIM is a little bit older, from the National Institute of Mental Health. This is from 2001 to 2003. And they saw that about 20% of the U.S. adults had a diagnosis of any anxiety disorder in the past year. So 1 in 5. So that's actually a pretty large number when you think about it. We see that that's disproportionately more females than males. And we'll see that as you age, we might see some decreases in this. So it's about the same in early adulthood and middle adulthood, starts to kind of level off and is down to 9% by the time we're into late adulthood. So generalized anxiety disorder is called generalized anxiety disorder because this individual is constantly tense, fearful, and in a state of autonomic nervous system arousal. So think back to our emotion chapter. Think back to when we talked about fear and we talked about arousal. We talked about the heart rate going up, the breathing going up, sweating, all of these things. In generalized anxiety, this person experiences these things kind of without knowing why they're experiencing these things. So this isn't like you see something scary and you have a fearful arousal response. This is just kind of this kind of constant, continual kind of fear, this kind of continual state of autonomic nervous system arousal. And the diagnosis and symptoms of it include persistent anxiety for at least 6 months. And again, this inability to specify the reasons for this anxiety. It can't be pinpointed to one thing or another. It is just, it's kind of this continual sense for at least 6 months. And the reasons behind it, well, there's different ideas. Back to our biological psychosocial approach. In terms of the biological factors, there's definitely a genetic predisposition that can affect this. We also see there can be deficiencies in GABA, which is a neurotransmitter, and we can also see differences in some brain structure, including the amygdala, which completely makes sense when you think about the amygdala and the role in fear. We also see, interestingly enough, that respiration can play a fact in this. So they've done studies where they've actually taken healthy volunteers and had them kind of change the quality of the air that they were breathing to increase the amount of CO2 that they were getting. And this heightened level of CO2 really induced fears of threat and anxiety, suggesting that respiratory system may have a role in anxiety disorders. We also see that psychological and sociocultural factors can be involved, such as really high and harsh self-standards. If you set a goal that's unattainable, then you're going to fear not being able to reach it because it's an unattainable goal. This can also come out of experiences with critical and harsh parents. We also see really these negative thoughts. And often ruminating on those negative thoughts, these uncontrollable thoughts. We can also see that trauma can be a cause or a trigger of a general anxiety disorder. So the next one we're going to talk about is panic disorder. Panic disorder is characterized by these unpredictable minute-long episodes of intense dread. So this is a panic attack, right? But they're unpredictable and they're really kind of overpowering. The diagnosis and symptoms, again, these are recurrent, sudden onset of intense terror without warning. And so again, these are recurrent and they don't know when they're coming. We can have biological factors for this. Again, genetic predisposition is going to be a big one. Neurotransmitters, including norepinephrine, GABA, serotonin. Also, another brain chemical lactate has been indicated as being related to panic disorders. Again, in the psychological factors, we're going to see CO2 showing up as a culprit. Only here, it's a psychological factor instead of a biological factor because we're talking about being conditioned to it. So kind of using CO2 as a trigger, this conditioning to CO2 as a trigger of this kind of response. Other sociocultural factors can include gender differences. Again, we tend to see differences between genders in this. Again, panic attacks are recurrent, and there's this constant fear that another episode might strike. So not only do they have the panic attacks, but then they have anxiety often because they don't want another panic attack. And so we see kind of removal from systems or situations where they might have a panic attack. In really, really extreme cases, panic disorder can lead into agoraphobia, which is that where we have that fear of leaving places, right? Fear of kind of being out in open spaces. That leads us perfectly into specific phobias. These are irrational, overwhelming, and persistent fears of a particular object or situation. So it could be a spider, it could be lightning, it could be darkness, it could be, again, kind of these open spaces, it could be high places. Again, there's numerous different specific phobias. And where these come from, the kind of causes, again, we see psychological factors. We think that maybe learning is playing a role in this, whether it be through conditioning or even vicarious learning. So not necessarily you being scared of something, not necessarily that you were encountered something, but you encountered someone else who was scared of this thing. So if you're a child and your parent is very scared of dogs, you may develop this fear of dogs having nothing to do with the dog themselves, just having to do with your parents' fear of those dogs. So that would be vicarious learning. Biological factors, again, there's probably a genetic disposition involved here too. So just like we've talked about this stress diathesis model, we have this kind of confluence of genetic factors with kind of the stress on the individual system, whether it be psychological or sociocultural, that really can trigger these disorders. So here are some examples of phobic disorders. Again, we can have ones that are fear of cats, pain, non-poisonous snakes, strangers, bees. Again, we have any number of different, and this is just a sampling of possible phobias. But again, these are specific. So somebody who has hydrophobia and has a fear of water isn't going to also be triggered necessarily by other things. This is a specific phobic disorder. And these can oftentimes be kind of precursors to other kinds of anxiety disorders. And so it's really important to get these treated early so that they don't kind of lead into something more generalized. In terms of the statistics on specific phobias, this is a little bit more current data from 2017. And we see that about 9% of the population really has had a specific phobia in the past year. So that's roughly about half of that overall anxiety disorder number. So they are more common than we think they are sometimes. And then also it's important to notice that we still see that social cultural factor of gender playing out here. So we see almost twice the number of females experiencing specific phobias than we do males in the United States. Again, obsessive compulsive disorder is not technically a DSM anxiety disorder, but we're going to cover it here just like because it does have some kind of anxiety provoking kinds of symptoms. So the diagnosis and symptoms include these persistent anxiety provoking thoughts and our urges to perform repetitive, ritualistic behaviors to prevent or produce a situation. Okay, so we have these thoughts and we have these behaviors. And so we have kind of two main components of this obsessive compulsive disorder. And again, it can be and or. So someone could maybe just be having problems with the thoughts. Somebody might be having more problems with the behaviors. Somebody may be having problems with both. In terms of the etiology, we can have, again, those biological factors such as genetic predisposition. We also see there's some differences in brain components, including the frontal cortex and the basal ganglia. We might have these areas be overactive. And obviously neurotransmitters are at play here too. Specifically, we'll see low serotonin, low dopamine, and low glutamate. In terms of psychological factors, life stress is a contributing factor, as is difficulty filtering out those negative thoughts. So when these people have these anxiety-producing thoughts, kind of not having necessarily the ability at the time to really filter out those negative thoughts as irrational. And so we see different kinds of behaviors and subtypes in OCD. Subtypes include things like hoarding disorder, skin picking, hair pulling, body dysmorphic disorder, things like that can be kinds of OCD subtypes. And we see that we have these two different pieces. The O in OCD stands for obsessions, and these are those repetitive thoughts. And this is the percentage of children and adolescents that report these obsessions or compulsions. So we see that about 40% of people with OCD report having these obsessions, these repetitive thoughts about dirt, germs, or toxins. Now, that's not the same thing as, you really want to wash your hands and you're really concerned about germs. That's not the same thing. This is, again, those overpowering thoughts that aren't able to be filtered out, that aren't able to be rationalized away. Terrible things happening, symmetry, order, exactness. Again, our culture tries to talk about OCD kind of as in the vernacular. So like, oh, you're so OCD just because you like things symmetrical. Well, that's not necessarily the case. Again, this is anxiety producing. This is where it's interfering with someone's ability to function, these obsessions. Compulsions in OCD, the C is repetitive behaviors. So we see the majority of people really express having engaged in excessive hand washing, bathing, toothbrushing, or other grooming techniques. Repetitive rituals such as in and out of a door, up and down from a chair. And sometimes these are going to be like highly repetitive, like counting a certain number of times that you have to do this. Checking doors, locks, appliances, car brakes, homework, these kinds of things are examples of compulsions. And these are, again, are the most commonly occurring within obsessions and compulsions. The next thing we're going to talk about is trauma and stress-related disorders. And so these are psychological disorders that are related to extreme negative experiences. So this is like a single horrific experience, but this can also be a pattern of negative experiences. And so this can be one really terrible thing, or it could be a series of terrible things. And the two disorders that we're going to talk about are post-traumatic stress disorder and dissociative disorders. Post-traumatic stress disorder, or PTSD, it really has that these symptoms develop as a result of exposure to a traumatic event, an oppressive situation, natural or unnatural disasters. Again, it could also come out of kind of repetitive negative or traumatic events. It doesn't have to be just necessarily one. People with post-traumatic stress disorder experience flashbacks to these traumatic events, avoidance of emotional experiences, and emotional numbness. We also see symptoms include excessive arousal, a very easy startle, difficulties with memory and concentration, impulsive outbursts. And we see that about 10 to 35% who experience trauma not only have burned-in memories, but also 4 weeks to a lifetime of these symptoms. So again, somebody with PTSD, this could continue for their entire life. And so sometimes you'll see things like around 4th of July, there'll be signs in people's front yard, that say, hey, someone here is suffering from, war-related PTSD, and so the fireworks are really a trigger for this individual, and so can you maybe refrain a little bit? And so we'll see that because these kinds of things will trigger flashbacks, they'll trigger these impulsive outbursts, again, these issues with memory and concentration. And again, somebody with PTSD, it may not be a series of, again, flashbacks. Sometimes we can just really see these kinds of memory and concentration issues. And again, this is very, very common in people that especially have been exposed to numerous traumatic events. Again, somebody who's been in the military in active combat, it's very, very common in those populations. Somebody that's experienced abuse or sexual trauma, these are very, very common kind of triggers for PTSD. People who are more likely to get PTSD are those who feel that they have less control in the situation. And so you can see how someone in an abusive situation or a victim of sexual violence or violence in general is going to feel less control in that situation. Again, more frequent traumatization is going to influence that. We'll also see that there's going to be some biological differences too. So we see people that have smaller amygdalas are more likely. We see a correlation between these brain differences and rates of PTSD. We also see differences in resiliency in terms of that as a psychological term. We also see those who get re-traumatized. So again, this is not something that's necessarily just happened once, but happened multiple times. And again, there's these genetic predispositions or family history. And that can be of someone who has either an anxiety disorder or post-traumatic stress disorder. So we see that kind of ups the risk of this. And that's, again, would be, indication for the support of that diathesis stress model, where we see that there's this genetic predisposition and then there's these environmental stresses that really can exacerbate these. The last set of disorders we're going to talk about is dissociative disorders. And we're just going to touch on these real briefly. These include things like sudden loss of memory or a change in identity. And these dissociations really deal with extreme stress. And it's thought of as a way to kind of for the individual to kind of deal with that stress, to disassociate from it. And so as a way to deal with this extreme stress, kind of remove themselves cognitively, psychologically from that situation. Because of that, then they're going to have problems integrating those emotional memories. And we can have two different kinds. We can have dissociative amnesia, where something traumatic happens, that's a trigger, and there's a period of time that's kind of lost, periods of emotional memory loss, things like that. And the more rare of these is dissociative identity disorder. This is what was formerly called multiple personality disorder, and this one's pretty controversial. And so we don't spend a lot of time talking about it in class here because it's both very, very rare and very, very controversial in terms of research on it. So there are documented cases of it, but the rates of it have gone up as it's more talked about, which indicate that there could be other kinds of things going on. Also, there's been reports of situations where identities have been formed kind of through therapy. And so again, this is problematic for kind of understanding it in a really clear-cut way. Okay, well, that ends our conversation on anxiety and stress-related disorders. Thanks so much.